Good morning to all. It's a pleasure to present the symposium entitled Insight onto the Utility of Magnetoencephalography and Electroencephalography for Studying Brain Disorder. Indeed, this symposium will focus on recent studies that employ MAG and EEG as a tool to investigate and characterize brain dysfunction. The live Q&A session of the symposium will be on September 8th, the second day of the conference. The first speaker is Dr. Gian Vittorio Luria from University of Genova that will focus on emerging tool to characterize the irritative zone of epileptic patients from MAG data.
Good morning or good evening, depending on your time zone. My name is Gian Vittorio Luria from the University of Genoa, and today we speak about a recently published paper in which an attempt has been made for going towards the automatic localization of the irritative zone through magnetic source imaging. This is a joint work with the Carlo Vesta Neurological Institute in Milan, with the Niguarda Hospital in Milan, and with the University of Genoa. Epilepsy is a neurological disorder which affects 50 million people worldwide, and about 30% of patients fail to respond to anti-epileptic drugs. When diagnosed with focal seizure onset, resective or disconnective surgery is an option for these patients, provided that the supposed epileptogenic zone is identified. In most cases, the localization of the EZ is achieved by means of routine electroclinical analysis, such as semiology, low-density EEG, and magnetic resonance imaging. And this leads to good seizure outcome after surgery. However, for about 30% of surgical candidates, the electroclinical data yield discrepant outcomes, or the MRI is contradictory or unrevealing. In such cases, invasive monitoring of the supposed EZ through the implantation of stereo EEG electrodes become necessary. Despite the use of these invasive techniques, surgery frequently does not lead to seizure freedom, and up to 40% of patients are still suffering from seizure relapses. Non-invasive functional neuroimaging techniques such as magnetoencephalography, high-density EEG, and others are expected to avoid or at least to guide the stereo EEG exploration. In this talk, we will focus on magneto source imaging, which has been shown to have a clinical value in predicting seizure-free surgical outcome, and which is increasingly used mainly for its excellent temporal resolution, which goes more than 1 kHz, which is combined with a good spatial resolution. MEG recordings of epileptic patients are mostly used to determine what is called the irritative zone, which is the cortical area where the interictal epileptiform discharges originate. The IZ represents a valid surrogate for the EZ localization. This has already been shown in the literature. The standard approach to IZ localization from MEG data comprises a data cleaning step, the IED identification in a MEG signal, possibly some form of data averaging. We will return on this point in a while, and then the source localization step at selected time points. We will focus on this last step, the source localization one. Equivalent current dipole fitting is the most widely used source localization method, and it is the only one which is recommended by the American Clinical Magnetoencephalography Society. ECD localization from MEG data is, however, a time-consuming and a complex procedure, which involves subjective choices, and therefore is reliable only when performed by experienced user. For example, typically there is a channel selection, and this choice is made by hand from the neurophysiologist. So, the main aim of this talk and of the paper is to investigate whether and to what extent traditional ECD fitting can be replaced by a more automatic and objective procedure. For doing so, we consider what is a retrospective study in which is formed from 22 patients with drug-resistant focal epilepsy. Of those, 9 patients showed cortical lesion on MRI images, and 12 patients underwent a pre-surgical invasive assessment by means of stereo EEG. Mag recordings were acquired at separated 1 kHz using a 306-channel neuromagnetometer. MRI images were acquired by means of a 3 Tesla scanner. MAG data were co-registered with the patient's anatomic MRI, and the raw MAG data were pre-processed with the TSS method. Before the analysis, a pre-processing step has been made. Data were bandpass filtered in the band from 1 to 40 kHz. Artifacts such as heartbeat or eye blinks were removed by means of independent component analysis. Only gradiometer channels were selected from the imaging recordings. And for each patient, the most frequent IEDs of similar morphology were visually selected by an expert neurophysiologist. As for the four-word model computation, for MRI negative patients, we consider a cortical subspace, whereas for patient with cortical lesion, we use a volume subspace. And the four-word solution was computed by means of a single layer boundary element method. Okay, so then we perform source modeling of selected individual ID topographies by means of the following methods. The single ECD fit, which in this study is considered as the benchmark, and then the Bayesian multidipole modeling with the Sesame, which is validated in this study in a sense, and 2 widely used other methods, which are rep music and weighted M&E. I want to underline the fact that we are analyzing each individual ID topography, so we do not perform the data averaging step. And this is done because when you perform the data averaging, you do this for enhancing the signal-to-noise ratio. However, you lose information, mostly about the extent of the IZ. We wanted to follow the hard way. We wanted not to lose any information, so we try to perform source modeling on each IED, on each topography, IED topography. And also I want to point out that ECD fit has a channel selection step, so the SNR is better with respect to the automatic method, which do not perform a channel selection. Okay. As for the method, Sesame is a Bayesian multidipole estimation method, which is an iterative Monte Carlo algorithm, which approximates the posterior distribution for an a priori unknown number of dipoles. So the number of dipoles is an unknown and is a part of the output. But in this case, we are explicitly looking for one focus. So we consider the last part of the solution which one source has been found. The output of the method is a posterior distribution for a variable number of dipoles and their parameters, from which a cortical probability map can be computed, which quantifies for each voxel the posterior probability of containing a dipolar source. And from this map, a point estimate of the dipole location as the peak of the map can be computed. We used the implementation in Python, which can be found at this address, this internet address, and we encourage you, if you want, to try the algorithm. The algorithm is also available in BISA research. Rap music is very well known as an automatic multidipole reconstruction method, in which the number of dipoles must be set in advance by the user, and we set it to 1. The output is a single current dipole, and we use the implementation which is available in the M&E Python package. VMNE is the most widely used inverse method based on the distributed source model. Is a weighted version of classical M&E, minimum norm estimate, and the weighted aims at removing the bias towards superficial sources. As for Sesame, here the output is a map, but it's a cortical intensity map, which quantifies the strength of the estimated electrical current at each voxel. So for sesame it was a probability map, now it is an intensity map. And from the map, again, one can compute an estimate of dipole location as the peak of the map. We use the implementation, again, which can be found in the M&E Python package. As for the performance evaluation, as we said, we use the ACD fitting analysis benchmark, and we made use of 4 different metrics, which are called the dipole localization discrepancy, the map localization discrepancy, the spatial dispersion, and the area under the curve. In particular, the dipole localization discrepancy is just the Euclidean distance between the ECD location and the source position estimated by the automatic methods. It evaluates only the quality of the point estimate, and it suffers from a systematic error because the ECD can be fitted everywhere in the cortical space, while the solution of the methods can be fitted only in the grid, in the source space. So we evaluated this systematic error as 2.65 millimeters. The DLD can be used to evaluate the performance of each method. The map localization discrepancy is given by this formula, where NV is the number of voxels, dj is the distance between the jth voxel and the ECD location, as jth is value of the cortical map at the jth voxel. The map localization discrepancy evaluates the discrepancy between the cortical map and the ACD location. And as we can see, it penalizes both the distribution that are highly peaked in a wrong voxel, as well as those distributions that are highly dispersed. It suffers from the same systematic error as the DLD, and of course it can be used only to evaluate those methods which outputs a map, so the sesame and VMNE. The source dispersion is very similar to the map localization discrepancy, with the only crucial difference that dj is now the distance between the jth voxel and the peak of the cortical map. So the source dispersion quantifies the spatial dispersion of each cortical map, and again it can be used to evaluate the performance only of sesame and VMNE. As for the area under the curve, it is a global measure of discrepancy between the set of all the equivalent current dipoles and the averaged cortical maps. It has been computed in the following way. First, the voxel whose value is above a given threshold are called active. The other ones whose value is below this threshold are called inactive. And then we distinguish the true positive as the ECD located in active voxel, the false positive as the active voxel in which no ECD has been fit, the true negative as the inactive voxel in which no ECD has been fit, and the false negative as the ECD located in inactive voxel. Then we computed the receiver operating characteristic curve as the threshold variant, and the area under this curve is the AUC. Then we also tried to give an answer to the following question. To what extent the cerebral lobes indicated by each method as the IZ were concordant to the ones that were included into the surgical plan? For doing so, we consider 5 regions in each hemisphere, so the frontal, the temporal, the central, the parietal, and the occipital. And for each method, a percentage was associated to each region. In particular, for ECD and rap music, we evaluated the percentage of dipoles that were estimated in that particular region. For sesame, we computed from the average cortical map the percentage of posterior probability in that region, and for VMNE, the percentage of estimated source intensity. The result was then defined to be concordant with the surgical plan whenever the corresponding IZ localization with the highest percentage was included within the set of regions that were selected to undergo surgery. Post-surgical outcomes were divided into 2 groups depending on the angle class which has been estimated at least 1 year after surgery. If angle class 1 the outcomes were considered good, and Engel class from 2 to 4, the outcomes were called poor. Results that were then classified with respect to concordance and outcome as true positive, where there was concordant with surgery and good outcome, false positive, where there was concordant with surgery and poor outcome, true negative, where there was discordant with surgery and poor outcome, and false negative, when there was discordant with surgery and good outcome. We then consider this statistical measure: the true positive rate, the true negative rate, the positive predictive value, the negative predictive value, and the F1 score. In our context, the true positive rate measures the proportion of good outcomes for which there is concordance with the surgical plan. The true negative rate measures the proportion of poor outcomes for which there is discordance with the surgical plan. The positive predictive value indicates how often the concordance with surgical plan predicts a caesar-free outcome, and the negative predictive value indicates how often discordance indicates a poor outcome. The F1 score is the harmonic mean of the PPV and the TPR. Okay. We now come to results. First, the DIPOLE localization discrepancy. We see that there is variability across subjects, and if we look at the violin plots, we see that there are three distributions with long tails, and when the ranges of the three methods are similar, the quartiles indicate that, as expected, the two dipolar methods outperform VMNE, and Sesame is providing a slightly better result than rap music. For the map localization discrepancy, we see that the probability map of Sesame is much closer to the ECD location than the intensity map of VMNE. From the source dispersion, we see that the average source dispersion of Sesame is significantly lower than the one of VMNE, and there is a correlation between the average ST and the average DLD, both for Sesame and for VMNE, and this means that when the uncertainty is small, the results also tend to agree more with those of double fitting. The average SD is significantly similar to the average MLD for Sesame, but not for VMNE. So VMNE maps are centered in location which are farther from those of ACD with respect to Sesame maps. As for the under the curve, we see that Sesame provides a greater or equal value of the AUC in 16 subjects out of 22, and the average AUC of Sesame is 0.94, while the average AUC of VMNE is 0.91. So these results indicate that the high probability region of Sesame hit the ECD location more often than the high intensity region of VMNE. These are the confusion matrices for the post-surgical outcome prediction, and these are the value of the statistical measure, and we see that all the automatic methods perform better than ECD fitting, and that Sesame is the one that does the best job. So, in conclusion, we see that the results are encouraging, although they must be confirmed by further prospective studies on a larger cohort of epileptic patients. In the majority of cases, the three tested methods show good agreement, both with ECD fitting analysis and among themselves. VMNE yielded the most discrepant result with respect to ECD fitting, and Sesame is the one that got closer and provide also an indication of the reliability of the solution itself. Concordance between Sesame localization and the surgical plan showed to be a good predictor of seizure freedom. So we may say, in conclusion, that the results seem to indicate the feasibility of replacing manual dipole fitting with automated methods in a source modeling step of the presurgical evaluation of the epileptogenic zone. So I will thank you very much for the attention.
The second speaker is Tea Giacomini, PhD student in clinical neuroscience from University of Genoa, and she will talk on the role of the REM sleep microstructure in the ESIS syndrome.
Good morning. First of all, I want to thank the organizer of the opportunity to present our work. Today, I will present our project about the role of the REM sleep microstructure in the ESIS syndrome. It is known that sleep is made by two main states, as classified by the American Academy of Sleep Medicine in 2007. In particular, non-REM sleep, that is characterized by the alternance of sigma activity, typical of sleep spindles, and slow waves delta activity, as recorded by EEG, and REM sleep, characterized instead by the presence of rapid eye movements and by theta alpha activity, that are more similar to the activity recorded during wakefulness. There is a strict relationship between sleep and epilepsy. In fact, it is well established in various types of epilepsy that the two main sleep states exert an opposite effect on epileptic activity. In particular, non-REM sleep promotes the spread and propagation of interictal epileptiform discharges, while EEDs are suppressed during REM sleep. In the last year, many studies have highlighted the fact that REM sleep is not a homogeneous state, but is actually made up of alternation of two different microstates. The phasic REM sleep, which is mainly characterized by bursts of 5 movements, and the tonic REM sleep, which consists of the longer and apparently more quiescent segments of REM sleep in between periods of phasic activity. Recent studies on patients affected by focal epilepsy have shown that the suppression of interictal epileptic activity within REM sleep is mostly exerted during phasic REM, in particular during bursts of ocular movements. This has been interpreted as the result of the depolarization of the thalamocortical neurons, which seems to be especially related with the phasic REM microstates. It has also been postulated that the suppressing effect on EEDs may be connected to the production of acetylcholine, which again is mostly raised during phasic REM sleep. The most impressive EEDs activation and diffusion during sleep is observed in a rare pediatric syndrome called electrical status epilepticus during sleep, or ESES, which is characterized by a strong sleep state dependency with a pathognomonic EEG pattern that you can see in the figure of continuous bursts of diffuse spike and wave during non-REM sleep that become fragmented, less continuous, and localized while entering in REM sleep. ESES may be associated with an encephalopathy characterized by a neuropsychological regression, behavioral and motor disturbances that appear together with abnormal EEG pattern. Usually, epilepsy shows a long-term good prognosis in those patients, along with an EEG normalization over time, but cognitive and behavioral deficits may persist. The aim of our work was to assess if the superiority of phasic REM protective effect holds true even in the extreme condition of spike activation during sleep, which is represented indeed by the electrical status epilepticus during sleep. To achieve our aim, 8 patients affected by ESES were consecutively enrolled for this analysis over the last year. The diagnosis was made through the presence of almost continuous spike waves in the sleep EEG, with epileptiform activity occupying more than 50% of non-REM sleep, according to the International League of Epilepsy classification. For each subject, we, moreover, collected data concerning the clinical and neurological status, the type and frequency of seizures, the ongoing pharmacological treatments, brain MRI results, and the cognitive profile. All patients underwent long-term EEG monitoring, also with electrocardiography, electromyography, and electrooculography. Whole night sleep has been divided into 30 seconds epochs, and each epoch has then been classified into non-REM or REM sleep stage by visual inspection of EEG signal and according to standard criteria. By a further visual analysis of the oculographic channels alone, each REM epoch has then been subdivided into segments of phasic and tonic microstates, being the phasic stage characterized by burst 5 movements, having a duration of at least 3 seconds. Here in the graph, you can see the distribution between non-REM, tonic REM, and phasic REM in our patients. Due to the highly extended portion of sleep covered by epileptic activity, visual detection of yads in a whole night sleep recording require a very long work time. Moreover, in many parts of EEG recordings, the detection of the yads is difficult due to the presence of artifacts or sleep physiological graph elements. To overcome these issues, we decided to use a semi-automatic method aimed at finding peaks inside EEG signal on the basis of given peak properties. In order to characterize the yad morphology, we set some parameters for each subject and each EEG channel. For example, peak, height, width, and prominence. This quantity of epileptic activity during each sleep stages has then been assessed individually for each EEG channel by means of a spike index. Spike index is defined as the ratio between the number of yads in each sleep stage and the time in seconds spent in that stage. The proposed yads detection method has then been validated to assess its reliability. To this aim, 60 non-overlapping 30 seconds epochs have been randomly chosen for each patient from the whole EEG recording, and each yad visually marked blind by a clinical neurologist and compared to the semi-automatic method result. The table you can see in the slide summarizes the numerical results of the validation. We found a fairly good agreement between the visual scoring and the algorithm. Cohen's K was greater than 0.75 in half of the cases, showing an excellent agreement. In the remaining cases, K was anyway greater than 0.6, showing a good agreement. The spike index computed from the visual scoring were strongly correlated with those obtained by the algorithm. The figure you can see in the slide shows the violin plots of the average spike index across all EEG channels of the 8 patients in the different sleep stages. As we expected, the spike index was considerably lower during the REM sleep stages compared to non-REM. And within REM, the phasic REM microstate exerted the greatest suppression of the yads. By evaluating the inhibitory effect on yads in terms of the spike index for each patient individually, and then taking the median across patients, we see that the spike index is reduced by 84% in tonic REM with respect to non-REM, and that it is reduced by 97% in phasic REM with respect to non-REM. Moreover, the spike index is reduced by 87% in phasic REM with respect to tonic REM. The statistical analysis proved the significance of our results. The figure in the slide portrays the topographic maps of the spike index ratios between the phasic and the tonic REM microstates. As you can see, there is not any clear evidence towards a lack of space homogeneity in the yet suppressing effect exerted by fuzzy cream. The suppressing effect of fuzzy cream on YEDs seem indeed to be widespread and homogeneous with respect to the topographic location of YEDs, although in a few subjects, minor differences were observed at the level of the frontal lobe. Usually, in other forms of epilepsy, we observe a reduction of YEDs overnight. We then decided to analyze if there was any difference between the first and the second half of the night in our cohort. In the upper panel, the point plots of the spike indexes evaluated in 2 half of the night sleeps are reported. The lower panel carries information about the ratios between the spike index in the second half of the sleep and those in the first half for each subject. We observed a general tendency towards a reduction of the spike index in the second half of the night, which is more evident when all the sleep stages are considered together, but that remains appreciable even when considering each sleep stage individually. In conclusion, in our ESES cohort, the spike index was reduced by 87% in fuzzy cream with respect to tonic cream. Our results, together with those obtained in previous studies, bring evidence that fuzzy cream exerts an inhibitory effect on the production of spikes, independently of the extent of YED's activation in sleep, topographical factors, histopathology, epilepsy syndrome, or even the age of the subject. Why fuzzy cream has this important inhibitory effect on epileptic activity is not yet understood. Fuzzy and tonic REM periods represent 2 different neural states, and in particular, electrophysiological studies suggest that fuzzy REM represents a state of high cortical activation similar to active wakefulness, while tonic REM is more close to a state of relaxed wakefulness. Fuzzy REM is characterized by higher levels of desynchronization, both locally and globally, compared to tonic REM sleep. And this could partially explain the inhibitory effect of fuzzy REM on YEDs. Such a desynchronization effect of fuzzy REM sleep seems to be related to high cholinergic activity, typical of REM sleep and particularly elevated during fuzzy REM. At the end, understanding the underlying mechanism of a protective effect of fuzzy REM sleep on epileptic activity might have relevant importance for future therapeutic approaches in the field of epilepsy. Moreover, interestingly, a selective enhancement of rapid eye movement sleep by deep brain stimulation of the pedunculopontine nucleus has been shown in humans. The pedunculopontine nucleus could be indeed considered a deep brain stimulation target for intractable epilepsy, and further studies are worth to conduct on this topic. I wanted to thank all of you for your attention and all of the team who helped me to complete these studies. Thank you.
The next speaker is Dr. Golnush Alamian from University of British Columbia that will focus on a methodological approach to evaluate frequency-specific alteration of brain activity in schizophrenia patients.
Hi everyone, my name is Golnush Alamian. I'm so happy to be taking part in the 2021 World Congress of Psychophysiology. First of all, I'd like to thank our symposium organizer, Dr. Annalisa Pasquarella, for putting this together and having us around chat about some very interesting things. So today, I will be providing some insight into how the brain's temporal dynamics can be characterized using resting state MEG signal. And specifically, we're going to look at how all of these are altered in schizophrenia patients. The work that I'll be presenting today was completed during my doctoral studies, where I studied the resting neural dynamics of schizophrenia patients from a temporal perspective by characterizing scale-free dynamics. And scale-free dynamics, as I'm sure some of you already know, is related to the idea of criticality in the brain. And this is some concept that we're going to be coming back to throughout this talk. So let's start with a little bit of overview. We know that the brain signal is composed of different types of activity, so both rhythmic and non-rhythmic or arrhythmic activity. And we can clearly look at this if we plot the log-log plot of a typical power spectrum where we have frequency on the x-axis and power on the y-axis. And the bumps that we typically see in this orange circle are the rhythmic brain fluctuations that we're all very familiar with, so the oscillations. Next up, when we look at what's going on that larger, longer part of the signal, what's in the red circle, well, this is something that's following the straight negative slope in a 1/f power law, and this is the arrhythmic part of the brain signal. And the field of neuroscience has been really uncovering that this activity in the arrhythmic part is not noise, which was typically filtered out throughout these past years, but it actually contains some important information, and it informs us about processes that are characteristics of a state of dynamical criticality. When we think of the state of criticality, this is a state at where we are at the cusp of order and disorder. And this state is thought to be very important in terms of efficient brain functioning and long-distance communications between neural regions. It's also thought to require an important balance between irregularity in the signal, so some structure in the signal, as well as flexibility, so a little local variability, all of which are said to be have scale-free properties. And these properties have been observed to be preserved across both spatial and temporal scales, as well as being found in both the rhythmic and arrhythmic or non-rhythmic part of the neural activity. So throughout the whole brain signal, we can find these scale-free activities. And one way to measure them is to use self-similarity and multifractality. And today we're going to be looking at both in the pathology of schizophrenia, because as it turns out, disease and psychopathologies can affect the physical and temporal structures of resting brain signals. Now, as most of you already know, schizophrenia is a debilitating illness. Patients are typically presenting with both positive and negative symptoms, so hallucinations, delusions, anhedonia, along also with some motor disorganization and some cognitive disturbances. And worldwide, there are over 20 million people that suffer from psychosis-related illnesses. And while there has been a lot of research advances in terms of neuroimaging in schizophrenia, the progress in our understanding in the neural mechanisms of their symptoms is still moving slowly. And over the past couple of decades, the main theory that has emerged to explain patients' symptoms has been that of neuroanatomical and functional disconnectivity. And this idea of disconnectivity is really what we're going to dive into here. At the functional level, the theory of disconnectivity has gotten most of its support from MRI studies and fMRI studies, and mainly in terms of spatial disconnectivity. But what we've noticed is that the picture is still unclear. We're still missing an important part of this idea of disconnectivity in schizophrenia. So we thought it would be important to actually look at this question from a different perspective and see whether disconnectivity can also be found in the temporal domain. One way we can tap into temporal disconnectivity is by measuring long-range temporal correlations, or LRTCs. LRTCs are thought to measure the autocorrelation of a signal in time. So basically, we're looking at the correlation of the signal with itself in time, and it's a measure of self-similarity in this rhythmic part of the brain signal. And importantly, it's thought to speak of the integrity and memory of the signal, and has been found to be highly heritable and altered by disease. Now, the way we measure long-range temporal correlations, or LRTCs, is by using detrended fluctuation analysis. And we're throwing another acronym at you here, so DFA, which is computed on the envelope of oscillations. And basically how this is done is that we start off with our raw EEG or MEG signal. We extract a frequency band of choice, so alpha in this example, and we look at how the envelope changes using a sliding window in time. And what we obtain is a value between 0 and 1, where 0.5 implies that the system does not have any memory, it's random, and anything above 0.5 or below implies that it's either positively or negatively correlated with itself. So the first study we're going to be looking at is going to be tapping into this self-similarity component of scale-free dynamics in the rhythmic brain activity. Specifically, we compared how resting MEG signal of schizophrenia patients and controls differed in terms of LRTCs across different frequency bands. We also looked at the relevance of these alterations in schizophrenia using a machine learning framework. And finally, we examined and characterize all this at both the cortical and subcortical level in the brain. So this study was made possible with the collaboration of Dr. Krish Singh at Cardiff University, and the details of the whole study can be found in our recent publication in Neuroimage Clinical. But briefly, our participants consisted of 25 chronic schizophrenia patients and 25 healthy and matched controls. Everyone underwent 5 minutes of resting state MEG recording along with an anatomical T1 MRI scan. In terms of analysis, oscillatory amplitude and LRTCs were computed at the source level across over 8,000 nodes, and we used NeuroPython and MiniPython for these analyses. In terms of statistical analyses, we used conventional t-tests that were corrected for multiple comparisons, along with a machine learning, supervised machine learning framework, so support vector machine with a tenfold cross-validation corrected with maximum statistics and 1,000 permutations. So our first group analysis found that in the alpha and beta frequency bands specifically, but not in the other frequency bands, we saw some important group differences. Specifically, we have here the alpha band results in the first row and the beta band results in the second row below it. We have controls here on the right, patients on the left, and their T differences on the far right here. And basically what we see is that there was a significant reduction in long-range temporal correlations in patients. So the LRTCs were not, and the properties of the signal were not properly maintained in patients across time. So there was a disruption of information processing in certain brain regions in patients as evidenced by LRTCs. When we applied a machine learning algorithm to see if LRTCs could accurately classify patients and controls, we saw that this was indeed the case. And so if we use the alpha band LRTC values in the central gyri, the right frontal gyrus, the left temporal gyrus, and the temporal poles, we saw that there was a significant group classification of patients and controls. Similarly, in terms of subcortical structures, there are statistical significant classifications of participants that were obtained using alpha band LRTC as a feature from the combination of the left and right amygdala, the left hippocampus, the left thalamus, and the combination of the left and right cerebellum. Similarly, when examining beta band LRTCs, SVM classified patients and controls with up to 84% accuracy using the beta band LRTC values in the orbitofrontal cortices, or the orbital gyri, anterior cingulate gyri, and the left insular sulcus. And in terms of subcortical structures, statistical significant classifications of participants were obtained when using beta band LRTCs from the amygdala, caudate, and thalamus. Now, to ensure that the findings of the LRTC group differences were not mediated by simple differences in magnitude and amplitude, we ran all the same statistical machine learning analysis using amplitude as the core feature. Here, we found that the only primary significant result was actually in the gamma band, and that alpha and beta band amplitude were not significant at all. So this sanity check allowed us to confidently move forward with our findings in LRTC, and it also showed us that gamma band amplitude, and not LRTCs, can correctly classify patients and controls with up to 86% decoding accuracy at both the cortical and subcortical levels. So in summary, this first study showed that one of the main properties of brain criticality, self-similarity, is altered in the alpha and beta oscillations of schizophrenia patients. We also saw that the gamma band amplitude could be an important marker in terms of classifications of patients and controls. And together, this attenuation and temporal autocorrelation among schizophrenia patients brings in some new evidence for the theory of disconnectivity, but now from a temporal angle. And together, this observation of changes in scale-free dynamics in the brain activity is an indicator of temporal or disorganization in schizophrenia patients. Now, if we zoom back out and we recall what we saw at the beginning of the talk, we saw that the state of criticality requires a balance between regularity, so structure, and flexibility. And so regularity is that self-similarity part that we just tapped into, and flexibility is more the multifractal component. And if we recall, we can see that both in the rhythmic and non-rhythmic or arrhythmic part of the signal. So now that we had seen a little bit how the rhythmic part of the brain signal is altered in schizophrenia patients, we wanted to see what's happening in the arrhythmic part in terms of properties of brain criticality. We decided to look into the arrhythmic part in the follow-up study, where we used the wavelet P-leader and bootstrap-based multifractal analysis, or WLBMF, to examine both self-similarity and multifractality in the arrhythmic part of the signal. Here, we observed a clear rostral caudal gradients of ascending self-similarity and multifractality across both participant groups. So in the first row here, we can look at the group averages in terms of self-similarity values, and in the second row below it, we see multifractality. And in schizophrenia patients, we see that overall there is an increase in self-similarity in the frontal and temporal brain regions compared to healthy controls. And in terms of multifractality, we see a decrease in the parietal and occipital brain regions compared to controls. So overall, the first study revealed that there was a reduction in regularity and memory in the rhythmic part of the patient's brain signal, specifically in the alpha and beta frequency bands. And this could be reflective of a break in communication and difficulties for the propagation of information through oscillations. And it really lends support to the spatial temporal disconnectivity theory in schizophrenia. In our second study, we saw, on the other hand, that there was an increase in regularity in the arrhythmic part of the signal now in schizophrenia patients that could be indicative of temporal redundancy and persistence, and perhaps less efficient information processing. And this could perhaps be what's been underlying the sustained and persistent nature of symptoms in schizophrenia patients, for instance, their long-lasting auditory hallucinations and their patients' difficulty in breaking away from these symptoms. And finally, in our second study, we noted that there was a decrease in multifractality and complexity in patients which could suggest perhaps less flexibility in their parietal and occipital brain regions that might make it more difficult to adapt to incoming information. And this could be perhaps underlying some of the cognitive symptoms in schizophrenia patients and their decreased executive functioning, but obviously more work is needed for that. So some take-home messages away for all of you today. Well, all of our studies were based on the idea that complex systems like the brain, they operate and adapt to information most optimally when they're in the state of brain criticality. And for chronic schizophrenia patients, we show that there's a clear deviation in their balance between regularity and flexibility, so in terms of their self-similarity and multifractality across the brain signal. And we found that these changes in the state of criticality support the theory of disconnectivity in schizophrenia, and we're able to correct there is a new way in which information interruption occurs in these patients from a more temporal perspective. And finally, we touched upon briefly on multifractal analysis, and this is a concept that's quite underdeveloped in clinical neuroscience, but we saw that there's an immense potential to really further our understanding of the temporal structure and geometry of brain signals in both healthy and diseased brain areas. So there's a lot more work to be done there. With that, I'd like to thank you all for listening to this talk. I would like to thank my PhD supervisor, Dr. Karim Jahbi, our collaborators, Dr. Krish Singh, Laura Knight, Dr. James Walters, Dr. Jean-Marc Lina, all the Coco Lab members and everybody who worked on this project. And I look forward to seeing you all, hopefully in person, at the next year's conference. Thank you so much.
The last speaker is Professor Laura Marzetti from University of Chieti Pescara that will talk on MEG resting state, oscillatory reactivity and connectivity in glioma patients.
It's a pleasure for me today to introduce to you our recent study on resting state, oscillatory activity and connectivity in glioma patients by using. So MEG is non-invasive electrophysiological techniques that allows us to disclose brain functional organization through the detection of the magnetic field generated by neuronal current. And the aim here is to derive the oscillatory properties of neuronal currents, both in terms of local oscillations and of coupling between oscillations pertaining to different brain regions and large-scale coupling of different brain regions. I mean, it's a long and well-known story nowadays that neuronal oscillation at the level of brain areas, and not only at the level of single unit or single neuron, can feature different properties which are modulated, for instance, by the stimulation or the execution of a task. But what we aim today here is to assess the properties of neuronal oscillations at different brain areas and their modulation or changes induced by the presence of the tumor in the brain of our patients. At the same time, we will in our study assess the phase coupling of neuronal oscillations which come from different brain regions. So the hypothesis here is that two different neuronal populations, such as the red and the blue one, will communicate if the respective oscillations are somehow phase aligned. So this will open some windows of opportunity through which the two neuronal populations are coupled. On the other hand, if two neuronal populations, such as the blue and the black one, have neuronal oscillations which are, for instance, in opposite phases, as in these cartoon examples, then it's impossible that these two neuronal populations will exchange information and will communicate. So this is the proxy that we will use to assess functional connectivity between different brain areas. Specifically, whenever we will see that two different brain areas, like the red and the blue here, have their phase difference, which is clustered around the preferred phase, then the two brain regions are coupled and functionally connected. Otherwise, when the situation is that the one represented by the black and the blue circles here, which represent two uncoupled brain areas, then the phase difference between the two brain areas over time will be completely random and scattered around the 360 degrees circle. So under this hypothesis, we wanted to study our population of brain tumor patients and to understand also what we could do more in terms of what, compared to what had been done before our study. So when we went to the previous literature in the field, what we observed is that there has been evidence for alteration in local synchronization processes, so indexed by local neuronal oscillations, and that this is specific to some brain areas and also to some brain rhythms, and more specifically, this is specific to the lower frequencies of our spectrum. At the same time, there have been studies regarding functional connectivity, which have shown that there are alterations also in functional connectivity in patients with glioma. And these alterations are not only restricted to the tumor area, but they are also spread all over the brain, even to areas which are contralateral to the tumor. Nevertheless, while interesting, these studies also evidenced some limitations. For instance, that they all considered some kind of full broadband activity or connectivity, or when they do take into account specific brain rhythms, they usually do that with standard frequency bands and not taking into account what the natural frequency of the individual subjects are. At the same time, most of the studies that I have mentioned, they do consider activity and connectivity at the level of channels, and from that try to infer what has happened in the brain of our subjects, and they most of the time also average across different sensors in a cluster. For instance, they talk about temporal channels rather than parietal channels and so on. But they do not take into account the different spatial location of the tumor in the different patients, meaning that when averaging across temporal, for instance, temporal sensors could have like a direct relation to the location of the tumor or be remote from the tumor itself. And all the studies on glioma patients with MEG functional connectivity, they use bivariate connectivity metrics, and this is something that I will go back later when I will discuss the method that we used in our study. So what we did then was to recruit two populations, one population of healthy subjects and one population of patients with brain tumor. Age were matched across the two populations. And, and in terms of data analysis and measurement, we first recorded 2 5-minute eyes closed resting state and the MRI of the individual MRIs of the subjects, and the MEG data were subject to ICA in order to clean them from the all biological and non-biological artifacts in our data. Then the clean MAC data were projected to the source space by using minimum variance beamformer on a like individual MRI derived source space and using a 3-shell boundary element method volume conductor model. So this is just a table summarizing the characteristics and the like the tumor grade and the tumor location of our patients. So the first thing that we did in our subjects and patients was to assess the so-called individual alpha frequency, which we defined as the frequency which exhibited maximum power in the occipital sources in the frequency range between 7 and 13 Hz. So when doing this, what we observed is that the median value of this individual alpha frequency for the tumor patients is significantly lower than the same value for the healthy subjects. So this immediately told us that we could not, if we wanted to compare healthy subjects with tumor patients, we could not use standardized frequency bands, and not take into account this difference between the alpha peak between the two subgroups. So for this reason, we decided to use individualized frequency bands, which rely on the value of the individual alpha frequency, and then define in the lower axis the low alpha frequency band, the theta, and the delta the delta frequency band, and on the higher frequencies the higher alpha frequency band and the beta frequency band. We then assessed the so-called band relative the relative difference for the NAI, as the NAI for a given frequency band defined for our target regions, which can be either tumor or peritumor, and minus the same value in the same frequency band defined for our control region, which can be either contralateral, pericontralateral, or the rest of the brain. And in doing this, we immediately realized that there was no difference in terms of band relative NIA, for any of the frequency bands between the tumor and peri-tumor region. So this somehow allowed us to consider the tumor and the peri-tumor region as regions with the same properties in terms of oscillatory activity. So we pulled together the tumor and peritumor region and also the corresponding contralateral regions, and assessed in terms of relative NAI the difference for all the frequency bands between the power in the tumor and peritumor and that in the rest of the brain or in the contralateral region. As a sanity check, we also considered the difference between the contralateral and the rest of the brain. So our results tell us that there is a significant difference between the tumor and peritumor regions and the corresponding contralateral regions in the lower and upper alpha and beta frequency bands, but also a significant difference between the tumor and peritumor and the rest of the brain in the upper alpha and beta frequency bands after correction for multiple comparisons. There is no significant difference between the contralateral and the rest of the brain, which, as I said, is kind of a sanity check showing that overall the non-damaged tissue behaves in the same way. With the same approach, we also assessed functional connectivity between different brain regions in terms of phase coupling of their respective neuronal oscillations. In order to do this, we relied on a multivariate connectivity metric, which takes into account the hypothesis that the source and the one brain area is represented by more than one single signal. So usually dimensionality reduction steps are employed to extract the dominant signal from brain area and then apply bivariate connectivity metrics. But in order to do that, when doing that, one usually can neglect some important source of coupling between different brain areas. So in order to take into account the full information that can be contained in one brain area, which represents the activity of multiple neuronal pools, we relied on a functional connectivity method based on vector activity, which is the multivariate interaction measure, the formulation of which can be found in the paper from Anne Ewald in Neuroimage 2012. So, and also when using this multivariate metric, what we did in this specific study was to consider the coupling between the region I, which is one brain area, the target brain area of interest, and all the other regions interest of the brain, which are here indexed by J. So when doing this, we calculated, the first thing that we did was to calculate this global MIM for the I region, which corresponds to the tumor region, or for the I region, which corresponds to the peritumor region. And similarly to the neural activity index, what we observed is that there is no difference between the connectivities of the tumor and the peritumor region in any of the inspected frequency bands. So, and this is again the measure that we derived, which is similar to the one that we had used before for the neural activity index. So X is now the target region, which will be tumor and peritumor pulled together, and Y is either the rest of the brain or the contralateral brain regions pulled together as well. So when we now expect this relative difference for the global MIM across the different frequency bands, what we observed is that there is a significant difference between the tumor and peritumor region and the rest of the brain in the lower alpha and upper alpha frequency bands, while there is no difference with the contralateral regions. So the most, at least not significant difference with the contralateral regions after permutation red test and correcting for multiple comparison. So actually what we can state here is that the way the tumor and peritumor region connect to the rest of the brain is different from any other, like from the average of how all the other regions in the brain connect to the same rest of the brain. Having also our data for the control subjects, age-matched control subjects, we also wanted to assess the similar quantities, so the NAI and global MIM, also between the two populations, so comparing the healthy subjects to the tumor patients. And what we observed in doing that is that we have a difference in terms of power, so in terms of NAI, in the lower alpha frequency band between the healthy subjects and the tumor patients. And specifically, the tumor patients exhibit higher power in the lower alpha frequency band in comparison to the healthy subject. We have a similar tendency also for other frequency bands, for instance, for the delta band, but this unfortunately did not reach significance after correction for multiple comparison. So when doing a similar approach to inspect the difference in terms of GMIM across the whole brain, now not specific to a given region, so not of the tumor and peritumor, because healthy subjects do not have anything like tumor or peritumor region. So here the global MIM has been defined for each and every location in the brain, both for the healthy subjects cohort and for the patient cohort. So when we do this comparison, although we can see some increase in the connectivity of tumor patients in the, for instance, in the lower alpha or in the theta frequency band, none of these values was significantly different between the two groups after correction for multiple comparison. So overall, I mean, we don't have like a clear answer in terms of how the whole brain of the one group differs from the whole brain connectivity of the other group. Nevertheless, if we now inspect of this global MIM in the two cohorts, the difference between the values in the two hemispheres, so basically we disentangle the values of GMIM and not summing over all the brain voxels, but dividing between voxels in the left and in the right hemisphere, what we can see is still that there is a higher value for the lower alpha in the tumor patients compared to healthy subjects, but still this does not really become significant after correction for multiple comparison. Nevertheless, if we then relate this normalized hemispheric difference, which we call the laterality index, and if we relate that to the volume of the tumor in our subpopulation of tumor patients, of course, what we can see is that there is a significant correlation between the two, and the correlation is negative. So meaning that those subjects which have a higher value of laterality index, so in which the connectivity, the global connectivity to the rest of the brain is higher in one hemisphere compared to the other, also have a smaller tumor volume. While when the tumor volume increases, this hemispheric difference, so this laterality for functional connectivity is lost. So it's somehow the presence of the brain tumor when small makes the difference between the two hemispheres in terms of functional connectivity higher, but when then the tumor is much more extended, then this difference is no longer present in the brain of our patients. So to summarize the results of this study, for what concerns the connectivity and the activity within the patients group, we have observed that there is a reduced power in the tumor and peritumor region in alpha and beta band compared to the rest of the brain, including the contralateral regions, and there is also at the same time a reduced connectivity in the alpha band compared to the rest of the brain. So the tumor affects not only its surrounding but also large-scale properties of brain functioning. When comparing the patients to the healthy control cohort, we observed an enhancement in the power, in the low alpha power of tumor patients with respect to the healthy subjects. And at the same time, in terms of connectivity, we observed that the lateralization of this connectivity in the theta frequency band, so in the lower frequency band, is related to the volume of the tumor. In a way that the larger the volume and the smaller the difference between the connectivity in the two hemispheres. With this, I want to thank you for your attention, and of course all the people that have contributed to the work that I have shown today.
Thanks to the IOP committee to give me the opportunity to organize this symposium, and thanks to all speakers to accept to join it, and thanks for their very interesting contribution. And thanks to you for your attention. I hope we can meet each other in person the next time. Thanks.